hope you'll get something from my presentation. And the first thing you should get is I have no conflicts of interest. Paul already outlined the very long and painful and arduous process of treating neuroblastoma. We literally throw the kitchen sink at the patients, surgery, chemotherapy, radiation. I'm going to talk about one component of it, the autologous stem cell transplant, and whether there's an opportunity on considering another form of transplant, allogeneic transplant. And as Paul reviewed 5 years ago, was published that by adding immunotherapy to that platform, specifically by targeting GD2 in combination with IL-2 and GM-CSF, we were able to improve survival. However, we still have a long way to go. And so the hypothesis of today's lecture is really to ask, what can we do to improve the event-free survival from 66%? Are there tools now in our armamentarium that we can add to the transplant platform to make it more effective? And so the hypothesis I asked is, one, can we revisit the question of allogeneic transplant? 25 years ago, studies in both the United States and in Europe by Rupert and others showed that allotransplant does have some place for treating neuroblastoma, but several of the patients die of relapse and they develop graft-versus-host disease, and thus it's not superior to autologous transplant, and that's remained the standard of care. And so some of the new tools that have come out that we can talk about today are the immunocytokine that Paul Sondel talked about, but also I'd like to add a section on ex vivo expanded NK cells and whether either one of these or the combination can enhance a graft-versus-tumor effect. And then I'm going to close with a brief comment about LY49, or in the humans, the KIR molecules, and whether that can be an opportunity for a therapeutic. So this is a CIBMTR experience that was published in 2013 by Steve Grupp and many other people who basically retrospectively looked at the international experience of using allotransplant. And the basic summary of it was that patients who had had a prior autologous transplant who then got an allotransplant later for relapse, as you would predict, did worse than patients who had never had a history of autotransplant. So there were some patients who benefited from an allotransplant, but if you look at the survival curve, it's still pretty abysmal. The number one reason why those patients didn't survive was because of relapse. So that told me that while there's probably some graft-versus-tumor effect just by doing an allotransplant, we need to add something on top of it to make it better. In addition, as I mentioned before, 25 years ago, they realized that they were getting a lot of graft-versus-host, and we need to find ways that we can limit graft-versus-host disease. And so I'm going to talk about the immunocytokine, and again, Paul already went into this, but we're looking at an anti-GD2 monoclonal antibody with IL-2 at the immunologic synapse. And as he mentioned, the phase 2 study had a 21.7 response rate in MIBG positive patients or patients with ONI disease in the bone marrow. All of those responses were CRs. However, if the patient had bulky disease, they did not respond. There's also preclinical data from Paul's lab that shows that the mechanism of action was through ADCC of NK cells. So this begged the question for me. These were just given as a single agent infusion to relapsed patients. What if we gave it in the setting of allogeneic transplant, and what if we combined it with NK cells? So this is the model that we can carry forward for the rest of the slides. It's a murine model, haploidentical. The donor is CD45.1 black 6 mouse, and the recipient was a black 6 mouse crossed with an AJ mouse. So it's a parent into F1 model. So it's a haploidentical MHC mismatch model. And after 10 days, the animals typically engraft with the donor cells, and they're challenged with a murine NXS2 tumor, which is a GD2 positive tumor. After challenged with the tumor, they'll be treated with the immunocytokine 3 consecutive days. And in some groups, they'll also get an NK cell infusion. The first logical question we wanted to ask is the immunocytokine even worth testing in the allogeneic setting, or should we just stick with the autologous or syngeneic setting because there'd be no graft-versus-host in that? And we found that the tumors were actually smaller in the allogeneic setting. But one question I had is, I noticed this huge variation in the sizes of the tumor, and that was because some of the mice, about 40% of them, had no tumor at all. And so either some mice got tumor and eventually succumbed to it, or some of them didn't develop at all, and that only happened in the allogeneic setting. All of the syngeneic mice developed tumor and died. So the first question we asked is, let's look at graft-versus-tumor effect and see if the immunocytokine and the IL-2 specifically could induce graft-versus-host disease. So I'll walk you through this. This is a weight curve here. And what we're looking at with the green and black lines are two groups that didn't get any T cells. So they gain weight, they don't develop graft-versus-host disease. And we can show that the black group gets the immunocytokine, and because there's no T cells, we don't see weight loss or graft-versus-host disease. But if you look at the bottom two lines, the blue group is a group that got T cells and thus developed weight loss and graft-versus-host disease. And in fact, when we add the immunocytokine, we also see weight loss and graft-versus-host disease. And in fact, when we look at survival, it ends up being lethal graft-versus-host disease because it's MHC mismatch. So as long as there's no T cells, we know the immunocytokine is safe. The next question we wanted to ask is there some small dose of T cells we can get away with where we would not see graft-versus-host disease, but we may see some graft-versus-tumor effect? And so I titrated down the T cell dose from in the million range and then just dropped it down a log. And as we saw, as we dropped it down a log, the percent survival from graft-versus-host disease improved. But still, even at 2 × 10⁴, there were still at least a few mice that were dying of graft-versus-host disease. So then we dropped the dose down really low to about 2 × 10⁵, 2 × 10⁵, and then finally we were able to see survival, 100% of the mice surviving from graft-versus-host. So we found a critical threshold of T cells that we could leave within the graft, not get graft-versus-host disease, and ask the question, what is the graft-versus-tumor effect? And what we saw, again, I'll walk you through these groups. This is a tumor growth curve. In this black group here are a group that got T cells but got no immunocytokine. And you can see that they developed very large tumors. In the green here, you have a group that didn't get any T cells and didn't get antibody. Now in our experimental groups, we see that if we give the immunocytokine, regardless of the presence or absence of T cells, it does the best job of controlling the tumor. When we looked at immune reconstitution in these mice in the spleen by flow cytometry, we saw that the higher the dose of T cells, the less B cells were recovered. And that typically in murine models is a correlative marker of graft-versus-host disease. But importantly, when we looked at the amount of NK cells in the spleen, the more T cells that were aboard, the less NK cells recovered. And this is very important when you're giving a molecule that requires T cells for it to work. And so if we now know if we have graft-versus-host disease, the mouse has a risk of dying from it. And even if you try and enhance the graft-versus-tumor effect, it's not going to have any cells or a sufficient number of cells to respond to the immunocytokine. So the next question we asked is, well, is there a way that we can infuse NK cells so that regardless of the amount of NK cells that recover from the transplant, there are effector cells present that can respond to the immunocytokine? And the advantage of doing this in the allogeneic setting is you already are set up to have alloreactivity because the host is going to have MHC molecules from both the H2B and the H2A. And the donor cells are going to be from H2B. So knowing what we understand about NK cell relationship, right, the inhibitory receptor, be it LY49 or KIR, has to bind the MHC to be turned off. And if that MHC isn't present, which in this case is H2A, the receptor is not going to be present on the donor NK cell, there's a potential that the NK cell could lyse the cell. On the other hand, if we did this in the syngeneic setting, the H2B donor NK cells would bind H2B on the recipient because they're syngeneic and would be turned off. So we used a irradiated YAC1 tumor cell line that was transfected with 4-1BB ligand, which was published by Rimis Arenas. And we co-cultured that with murine NK cells. But we also knew that the cells need some cytokine support, so we included in the culture an IL-15 and IL-15 receptor alpha complex, so that in combination the cells would get stimulated by IL-15 and 4-1BB ligand and get good cell expansion and hopefully potent NK cell activation. In vitro, when we examined the cells, we saw that after a week in culture, the NK cells that were expanded with this method made very high levels of TNF-alpha. And when you put them in a cytotoxicity assay against either YAC1 or A20 lymphoma cells, the ex vivo expanded NK cells killed superior to cells that were just in IL-15 alone. However, when we infuse the NK cells in this model in combination or without the immunocytokine, the ex vivo expanded NK cells in and of themselves cause all the mice to die of graft-versus-host disease. And in the presence of the immunocytokine, we saw the same thing. And this is, again, with very low doses of T cells, just 10 to the third. This observation has already been reported clinically by the NCI, not in the haploidentical setting, but in the match-unrelated donor setting, in patients who received ex vivo expanded NK cells with the thought that they may have expanded the residual T cells in the graft and caused GVHD. So lastly, we looked at using ex vivo expanded NK cells that were from TNF-alpha deficient mice, given that our in vitro data showed that they were making high levels of TNF-alpha. And interestingly, the mice who got the immunocytokine in the ex vivo expanded NK cells actually developed the largest tumors, probably because the development of the graft-versus-host disease impaired any graft-versus-tumor effect. However, if we used NK cells that were from TNF-alpha deficient mice, we were able to see an improvement in the graft-versus-tumor effect. But the group that had the smallest tumors was the group that just got the immunocytokine alone. And that's probably because if you can give the right dose of T cells and thread the needle between not developing GVH but having sufficient amount of cells for GVL, you'll get the maximum effect. And lastly, just one thing I want to comment on is we've heard a lot today about checkpoints and exhausted T cells. And in NK cells, they can express these molecules as well. But the other thing that happens in culture is you get the enrichment of certain LY49, or in the human, again, KIR subsets. And that's something that in the prior publications people haven't really looked at, and I would encourage you to look at going forward. So for example, when we expanded our cells in culture, you would think LY49H, which is an activating ligand on NK cells from B6 mice, would be way up. But there was no difference between unexpanded cells and expanded cells. But when we looked at LY49CI, which is an inhibitory receptor, it goes up, sort of like PD-1 goes up when T cells are activated, and it eventually becomes a marker of exhaustion. And so this leaves open a possibility, as Nikon alluded to in his talk, of using anti-KIR or anti-LY49 technology to maybe control those NK cells that would be inhibitory in your system. And there's already one in the clinic in trials with a PD-1 antibody at MD Anderson. So in conclusion, I've shown you today that the immunocytokine humanized 1418-IL-2 can be safely given after allogeneic transplant if the T cell dose in the bone marrow is limited, and it can contribute to a graft-versus-tumor effect. However, if you add ex vivo expanded NK cells to enhance GVT, you end up exacerbating GVHD. Inhibiting TNF-alpha may be a therapeutic target by which to block GVHD, and it may preserve GVT. So I'd like to thank the members of my lab who've worked on this, and in, of course, a critical collaboration with Paul and specifically Sasha Rekmilovich in the lab, and these are my funding. Thank you.